While we have made huge inroads into the therapy for locally advanced and metastatic cutaneous squamous cell carcinoma of the skin and basal cell carcinoma of the skin, there still remains a lot of questions to be answered. We have high response rates in these tumors with immunotherapy, but more than 50% of the patients are not responding. So the question there is, how can we improve immunotherapy to benefit these patients? Would it be better predictive or prognostic markers? Would it be combinatorials that elicit a better immune response, either by priming the immune system and then boosting with checkpoint inhibitor, or working together simultaneously? We have the ability to utilize other types of immunotherapy for our patients. There is ongoing experimentation through clinical trials with oncolytic viral therapy, that's direct injection of immunotherapy into basal cell carcinomas and cutaneous squamous cell carcinomas of the skin, with some interesting results. We can look into other types of therapy, whether it is CAR T therapy or other types of immunotherapies for our patients. Obviously, for basal cell carcinoma, the ability to combine targeted therapies with hedgehog inhibitors and immunotherapy should be looked at. And as we've said, there are mutations that exist in cutaneous squamous cell carcinomas, that exists in head and neck squamous cell carcinomas, and the ability to target those either singularly or in conjunction with immunotherapy through checkpoint inhibition is being looked at currently.
When thinking about unmet needs for basal cell carcinoma, I think two areas exist. The first is what to do when that patient is intolerant of a hedgehog inhibitor or when that patient progresses on a hedgehog inhibitor. Because right now there's a lot of unanswered questions, as I mentioned, as far as what the next line of therapy should be. Is immunotherapy appropriate, or is EGFR inhibition appropriate, for example? And that latter question can probably be answered by more mass next-gen sequencing to see what other markers or what other genes might be playing a role in that particular patient population. The other thing to keep in mind is those rare patients with Gorlin syndrome and what to do for them, because they oftentimes will exhaust the hedgehog inhibitor pathway early. With CSCC, there's a whole basket, I think, of unanswered questions. Primarily what to do for the very vulnerable solid organ and bone marrow transplant population. We know that by exposing those patients to immune therapy, we put them at risk of graft rejection, and don't know if there's a subset in the transplant patient population, for example, where it might still be safe to do it. So what are the safety and efficacy implications for patients who are immunocompromised because of prior transplant history? Similarly, what are the safety and efficacy implications for patients with a history of CLL or HIV? That's another patient population where there's a lot of CSCC that's seen. And then thirdly, with CSCC, thinking about those patients for whom immunotherapy is appropriate, what do we do when they progress on PD-1? I'm kind of borrowing some of these questions from what we know about melanoma, but we learned that with melanoma, by combining CTLA-4 with PD-1, we could significantly augment the clinical impact of those drugs. And so CTLA-4 is being looked at in combination. Is there a use for radiation plus cemiplimab or PD-1 therapy? Is there a role of intralesional therapy, and can we use that as a way to activate the immune system and combine that with a PD-1 backbone? And those are all actually very exciting research questions that are being answered now in clinical trials, so stay tuned. As a specialist in skin cancer who sees these cases every day, my advice to the listening oncologist would be engage with your team members early. Talk to your dermatologist, talk to your referring surgeons, your radiation oncologist, and have intelligent multidisciplinary discussions around what the impact of your therapy is and might be for that particular patient. We know that these drugs work well. We know that these drugs work fast. And oftentimes, to avoid the patient coming to you too late, get involved early in the discussion and advocate for the power of your therapy. That is absolutely something that I would say and would encourage everyone listening to this interview to do. So ultimately, we all want to achieve the same goal for our patients.